Hi, this is Dr. Naim Alkhouri. You are listening to the Surfing the NASH Tsunami podcast.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, C-suite veteran Peter Traber, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on this week's edition of Surfing the NASH Tsunami.
Everybody with an interest in NASH or more broadly fatty liver disease, surfs up. Episode 15 of Surfing the NASH Tsunami starts now. First of all, Stephen started last week's introductions by greeting us as hola. I'm going to go one better, and I'm going to celebrate our 15th episode by saying Feliz Quince. And to everybody who has any connection with Mexican or Hispanic culture, you know what I'm talking about. If not, send us a note, we'll let you know. Last week, everybody was here. This week, Louise is on a barge holiday with her family. Sunil is unavailable. Peter, Stephen, and I have the good fortune to be joined by Dr. Naim Alkhouri. Naim, welcome to Surfing the NASH Tsunami. Please take a minute and tell our listeners about your background, professional interests, and at least one interesting thing that they wouldn't know about you if they didn't know you well.
Thank you so much for having me. My name is Naim Alkhouri. I'm a transplant hepatologist at Arizona Liver Health in Phoenix, Arizona. I'm also the director of the Fatty Liver Program. I have a busy practice. I see many NASH patients with advanced disease, and we also do clinical trials, phase 2 and phase 3 trials in NASH. I don't know, one interesting fact about me is that if I weren't a doctor, I would be a musician. I play an instrument called oud, O-U-D, and it's like a Middle Eastern guitar, and my dream is to retire and have my own venue where I can play live music. Again, thank you for having me. Looking forward to this podcast.
So that's really interesting, because our question last week came from a friend of mine who's, among other things, a pharmaceutical economist and a award-winning chart-busting blues musician by the name of Dr. Mick Kolassa. So I need to hook you guys up sometime. The instruments are very different, but I think the aspirations are quite similar. So very neat.
That could be a nice combination, I would say. Mm-hmm. Blues and Middle Eastern music.
We will make it happen. So now, before we get started, I want to thank those of you who are listening. We got our new listenership numbers yesterday, and we've now learned that we have over 2,300 active subscribers, probably more like 2,500 to 3,000, but we've got to get all those numbers tallied up first. People from 47 different countries have listened to this program at least once. And right now, listenership in South Korea and India are the fastest growers in the world. So I don't know how word gets out, but you people continue to amaze us by showing up. Thank you for that, and thanks for your attention. Next subject. We are now 5.5 weeks away. Actually, today we're 5 weeks away from the EASL Digital International Liver Congress meeting opening up. Surfing NASH will be covering that meeting in some special ways. We'll be rolling out details of it over the next few weeks. If you have any comments, questions, requests for what you'd like to hear about the Digital ILC as it goes on, or about EASL, please click the Ask the Panelist question on the homepage. Send questions to questions@surfingnash.com. We're collecting your ideas so that what we put together is exactly what you want it to be. Okay, and on to our podcast. This week, our goal is to talk about professional highlights. Brave one, go first.
Hey, this is Stephen. I'll go first. So, professional highlight for me this week was surviving the AASLD abstract deadline, which was Friday. They came fast and furious, and all I can say is buckle your seatbelts. AASLD is going to be live, and it'll be rich with lots of data. Even though it'll be virtual, just like EASL, I think it's going to be a great digital liver experience for sure.
So at the risk of oversharing, at about 2:30 Eastern Time Friday afternoon, a slightly shell-shocked Dr. Harrison called me to ask if he had missed the appointment that we'd had scheduled an hour earlier because he had been up to his elbows in AASLD abstracts. Once he got done shaking his head, he talked about how good it was going to be. So I believe you, Stephen. I'm really excited, looking forward to it. And welcome back from abstract jail.
Thank you.
Who'd like to go next?
Well, I'll make a comment. First of all, it's exciting to hear that, Stephen, and I hope that these digital meetings improve as we go forward. I only had one abstract that I wrote for AASLD, unlike the many that you certainly had, and I'm looking forward to the format. I think that the other thing that I'll mention is a personal one. By the way, Roger, I did go listen to Michissippi Mick and listen to a bunch of his blues songs, his newest album and others. and he really is entertaining and terrific.
Thank you. He thanks you. It's Michissippi Mick. Now that you mentioned it, Peter, I have a special treat for our listeners today. Honorary surfer Michissippi Mick Kolassa singing a song whose title seems appropriate for an episode when our guest is a transplant hepatologist. This is Mick singing Recycle Me.
Think I'd like to be recycled. Baby, come here and use me again. I ain't nearly depleted. Got lots to share with a good friend. I may be tossed out, but I ain't used up. Recycle me, baby. This old dog still got a lot of pup. Sure, I got tossed aside. That was someone else's deed. I ain't a single-use guy. Oh, you can use me all you need. If you wonder what we can do, well, I have some thoughts. Come over here, baby. You can serve this natural resource. Look at me, baby. I'm renewable as I can be. I'm totally organic, and I'm gluten-free. If you want to know more, come here, let me give you a hint. I'm biodegradable. I have a very low carbon footprint.
Who says the liver can't be an exciting organ? If you have musical suggestions, particularly if you or someone else in the fatty liver community is the musician, let us know and we'll see what we can get on the air. Naim, one piece of good news.
Well, it's been very busy for me. I just moved to Arizona to join Arizona Liver Health. I was at a different institution, and I'm working with different mid-levels. We started a new office in Tucson, and to just add more flavor to it all, we started doing COVID clinical trials and learning about all different aspects of these trials and how to get patients enrolled in a safely manner. So it's been very busy. AASLD, I think, is going to be a great meeting. Several important abstracts will be presented, and I look forward to EASL to see how we do with this digital format, and I think this might be something we have to learn to live with for a few months, hopefully not too long, and I can now wait to meet my colleagues in person at a national or international meeting, hopefully in the near future.
Couldn't agree with you more. Hoping that we can all get back together by the time we get to Park City for NASH Tag in January. That would be fantastic. My highlight is that we've been working with several clients on an idea we call storytelling, which is helping people figure out how to make their story tighter, mostly for investor pitches. But now we've come to realize that sometimes our work is more like writing and directing a one-act play, in which we not only have to tell the script, but we have to block the characters and figure out kind of what everybody's role is. I'm not the thespian in my family. My brother is a career actor and director who wound up as a middle school counselor later in life, but that was after 35 years at the theater. So to be theatrical for once in my life is kind of a cool thing, and I think it's working out well for our clients. So we got several letters in last week, no questions, but I want to read you from one of them because I think it's kind of an interesting comment. One letter that came in said, and I quote, "Thanks for giving a fuller view of the role the liver plays in overall health. By the way, I'm troubled by the nastiness and unchecked biases inherent in the idea that if PCPs did their job better, we would not have obesity or diabetes, and that these are the, quote, real, unquote, problem. Respect for the liver is a great idea." So I don't know what thoughts you guys have about that quote or about the episode, but part of what it struck in me, again, is the idea that they don't teach people in medical school how to be behavior counselors, per se. That's a whole different paradigm, and that one of the things we need to get smarter about, I think, in the whole healthcare system is how to bring those two paradigms together. I'm still threatening that at some point this summer we're going to do an episode on wellness and illness and how the wellness people take help on wellness and help on illness, think differently about these things and what they can learn from each other. So thank you for that comment, listener. Anybody else have anything they want to say before we go on?
Well, having listened to the episode and the comments that we made, I can see how the listener might think that some of the comments are directed in a nasty way at primary care physicians. But I think that it's more challenging to all physicians. It's not just primary care physicians that need to think more about wellness and the positioning of the liver in overall health and diet and exercise and other lifestyle issues. So I think the podcast was really challenging the medical profession and not pointing fingers at one particular segment, such as primary care physicians. That's how I looked at it, Roger.
So, Peter, what you've just proved is what a crummy editor I am, because what the writer was referring to was the comment in the Intercept episode about NASH being a failure of primary care. And she felt actually that our episode did a good job of exactly what you just described, which was making the point that no, it's nowhere near that simple on a bunch of levels.
I got
so
you.
I owe you one, because I would have let that quote go up that way and people would have thought that you had it, what you said was right, and that they would have thought of the podcast in a completely different way. So my apologies to the author of the quote, my gratitude to Peter for helping get it right. Now, any other comments?
I mean, I like the concept of liver wellness and not waiting until we have an illness. And now with new non-invasive tests, I would love to establish a liver wellness clinic where people can come in, have their liver enzymes checked, and maybe get a non-invasive test such as FibroScan to make sure that their liver is okay. We don't have to wait until you're in trouble. And if you have any concerns that maybe your diet is not the best or you're drinking too much, you just go and see a liver wellness clinic and have peace of mind. Or if you need to be seen by a specialist, then you can be referred.
So Louise may be on a barge, but Naim just expressed her worldview perfectly, right? About test everybody. That's great. As I said, today we're going to start talking about EASL, which is in 5 weeks. EASL has announced 150 abstracted presentations and a whole bunch of other sessions. So far, we've only seen on the website abstracts for 16 of those. But with that said, as we start to move towards our coverage of EASL, we thought a good first step today would be to take a look, each of us, at 3 or 4 papers that we think will really be valuable. With that said, what we're going to do is take a paper that we find interesting, take maybe 3-4 minutes to discuss it, and then go on to the next. Our goal is going to be to get through somewhere between 8 and 12 papers in the next 40 minutes. All right. Stephen, why don't you kick us off?
Sure. Well, first of all, you can go to the website Digital ILC and you can see the program about what abstracts are going to be presented. We cannot yet download the abstract, as Roger mentioned, but we have the title. And I selected one from the non-invasive assessment segment of the meeting, which will be on Thursday. This is Abstract 100. The senior author is Naga Chalasani, who is a terrific researcher in his own right in multiple different areas, to include fatty liver, particularly the more advanced forms of fatty liver cirrhosis and also drug-induced liver injury. He's well versed in this area and I think is presenting what appears to be an exciting abstract entitled Progression of Liver Stiffness and the Development of Cirrhosis in Histologically Characterized Patients with Non-Alcoholic Fatty Liver Disease. So why do I think it's important? Well, we've talked already in this podcast on previous episodes about where we think the agency is going relative to endpoint analysis, and we know that progression to cirrhosis is important. And we know that that's also a marker of long-term outcome, because we know patients with cirrhosis do poorly. And a lot of our drugs are targeting the regression of fibrosis, but by further analysis, that also means delay in progression to cirrhosis. So I'm not sure what assessment tool they're using in this abstract. Progression of liver stiffness could imply vibration-controlled transient elastography. It could imply MR elastography. I suspect it's certainly going to include vibration-controlled transient elastography, although with a caveat that there may or may not also be MR elastography. But I think it's important for a lot of reasons. And if we're able to, put some goalposts or left or right boundaries around numbers of what percent change, what absolute number is associated with progression of development of cirrhosis. I think that would be incredibly valuable for clinical trial development, for our use in clinical practice outside of clinical trials. I think just getting to Naim's point earlier, if I'm able to do let's say a FibroScan in clinic today, and then I can bring that patient back in 6 months, a year, 2, 5 years, repeat it again, and I've seen an increase in liver stiffness to a point that is associated with development of cirrhosis, I think that's incredibly important information to have. I'm looking forward to learning more about this abstract and the data associated with it.
I selected a couple of papers related to the natural history of NAFLD. The first one is abstract 157. The title of the study is Liver Disease Progression and Clinical Outcomes in a registry called the Hepatic Outcomes and Survival Fatty Liver Registry, or the Hot Surfer study. This will be presented by Dr. Vlad Ratiu from France. He's been involved in NASH research for many, many years and is considered one of the key opinion leaders. This will be presented on Thursday, August 27th in clinical session, except therapy. So we know that NAFLD is a spectrum of diseases, and we know that patients with NASH and significant fibrosis are at risk of progressing to cirrhosis. We have studies from Sweden and several studies from the United States looking at the natural history and liver-related mortality, overall mortality, need for liver transplantation. But I think we need more studies to evaluate these patients presenting with earlier stages and see how many of them develop relevant clinical outcomes. And by that, I mean progression to cirrhosis, how many patients will develop decompensation, including ascites, variceal bleeding, hepatic encephalopathy, how many need liver transplantation, and eventually how many patients die from liver disease. I think, having more data is very important because this will help us determine cost effectiveness of any approach we use to tackle NAFLD. So whether it's early screening or cost effectiveness of new treatments, or even screening strategies for liver cancer, or the need for liver transplantation. So any data is a welcomed addition. We have some data from the NASH Clinical Research Network in the United States, and this will be additional data from France. So I look forward to learning more. The other abstract that will be presented at the same session, also related to natural history of NAFLD, as abstract 158, causes of death in patients with NAFLD. This will be data from the National Vital Statistics System, or NVSS. This will be presented by Dr. Zubair Yunosi, another KOL in NASH, especially patient-reported outcomes and natural history. And this is utilizing the most complete data on death in the United States. We know that patients with NAFLD are more likely to die from cardiovascular disease, followed by cancer. We know that liver death is higher in patients with NAFLD compared to the general population. We have some emerging data on extrahepatic cancers also being more prevalent in NAFLD patients and potentially contributing to mortality. So I think this is important data, and also it will help us understand the real burden of NAFLD, because we know NAFLD affect a very high percentage of the general population, but when we look at mortality and the need for liver transplant, this is the tip of the iceberg, but understanding this tip of the iceberg is very important to allocate healthcare resources and try to tackle this epidemic on every level, from early disease, looking at just simple fatty liver, all the way to liver transplant and decompensated cirrhosis.
Many of you will recall, and if you haven't listened to it, it's a good episode to listen to, our discussion several weeks ago following the complete response letter that Intercept received on obeticholic acid for the treatment of NASH. It brings up the very important issue of optimal endpoints in clinical trials. And so I've chosen a symposium to review on Thursday, which is entitled Optimal Endpoints in NAFLD Clinical Trials. histology, or non-invasive biomarkers and imaging. It's an all-star lineup. Matthias Eskat from Sweden will be discussing clinical trial outcomes and the relevance to patients' prognosis. Rohit Lumba will be discussing non-invasive outcomes, which ones and when. And Vlad Radzu will be discussing histologic outcomes, why it is still key. The combination of these three talks should be very enlightening to understand the opinions of key individuals about where we stand now with optimal endpoints in NAFLD clinical trials. It's something I think our audience will be very interested in understanding how these experts view the current state of affairs, and will help us think about how we go forward in clinical trials and focusing on the endpoints that are going to be most important and the ones that will lead to approval of drugs. So I'm going to evaluate that symposium on Thursday.
I almost picked exactly the same two papers that Naim did for the same reason, because we've talked about the different outcomes that stem from NASH. But what I landed on was AS101, convolutional neural networks of H&E stained biopsy images accurately quantify histologic features of non-alcoholic steatohepatitis. I landed on this for a couple of reasons. As we've discussed, getting a more reliable read on biopsy images, however we do that, is going to be pivotal to understanding what works, what doesn't work, and why, and then to be able to create independent risk factors for disease that you can pay off against what's in a biopsy, once you can read it consistently and with depth. So we hear a lot about AI, which on one level is about doing a better or more consistent job of reading. Neural nets are a little different. They take data from multiple sources to try to create or identify new overall patterns that make sense. And I've seen some interesting neural network in drug development. If any of you are familiar with the company Hepion Pharma, they do neural network as a way to figure out how to take best advantage of their assets, what combination therapies might look like and how to target it. And their work is really pretty exceptional in that area. What intrigues me about this is that I don't know the authors, but there was a company called Incitro, which has done some pretty amazing work, not in liver, but in a variety of other areas. And one of the co-presenters is Matthew Alpert, who's an immunologist by training and has run immunology departments at major institutions, has been involved with setting up some major tests and trials in unusual ways, was involved in Hep C testing with Epistem. So I believe they're going to come at this issue from a slightly different direction than the way we usually think about it. And to me, the question of getting this right is so important that I'm very excited to see what they come up with. So let me go back, because as anyone who listens to the podcast knows, one of the things I focus on is the 3 sets of liver outcomes. And by having a day where we're going to be focusing on fatty liver, as Peter discussed, and then as Naim discussed, papers looking specifically at outcomes related to end-stage liver disease and then related more broadly to all-cause outcomes, we should be able to make progress in understanding how those pieces fit together and what the real mortality picture around liver looks like. Maybe a little deeper, maybe a little wider than we had previously. When you add that to some of the things that will come later in the conference, I believe this is an area where we can make some real progress or learn some new things.
I mean, I may say something about artificial intelligence, and reading biopsies and improving consistency. But there was some work that was presented by Zubair Yonossi on behalf of Gilead using something called Path AI, which uses AI technology to basically improve the way we interpret liver biopsies in the context of clinical trials. And I see this as a better way to, have more quantitative scores for controversial histologic features of the disease, especially ballooning, also maybe providing more quantitative measures of fibrosis, because then we can really assess the improvement in response to therapy. However, no matter what we do, biopsy is going to be limited just because of the way we obtain the samples and how small the biopsy is. And so although, we can have a whole discussion on how biopsy is still the holy grail, I dream of a day where we never need to biopsy anyone with fatty liver disease, and we can actually determine the stage of their disease and their prognosis and response to treatment without an invasive test.
I second Naim's enthusiasm for machine learning and artificial intelligence. I think we've highlighted some of the limitations of liver biopsy already, but one that potentially we can improve on is, the interpretation of these response to therapy, if you will, by fully quantitative analysis. And he mentioned Path AI. There's actually quite a number of these companies looking at this, and I think it's a hot area and will be fruitful in helping the regulatory authorities understand the efficacy of these drugs and how it plays out relative to drug approval. The issue with non-invasive tests that I think are going to require a lot more work is, so far there's still a decent indeterminate range. If you pick a low cut point that's highly sensitive, has a strong negative predictive value, that's terrific. And we use that tool to the advantage of the fact that 80% of our fatty liver patients really have relatively mild disease and are very low risk. And I say low risk because it's not zero risk of disease progression. And then we can use the upper cutoff where it's high specificity and positive predictive value. And we know that a single test alone currently doesn't have good positive predictive value, but we've been able to sequentially combine them. And you see this starting to come out now with things like FibroScan, AST, and Naim, you're working on MRI and some other clinical variables to go into that improve our positive predictive value. But still we're narrowing that spectrum of indeterminate, but they're still there. So I think for quite some time, there's going to be a role for liver biopsy in patients that we just don't fully comprehend where they fit. They're not no risk or minimal risk. They're not high risk, but we're struggling to know what to do with them. And this is where I think, again, artificial intelligence will have a role to play for quite some time, even once we're to the point where we have a non-invasive test, because we're not to the point where we're so cut and dried that you're either risk or a lot of risk. There's a group in the middle that we're not granular enough to really define yet.
So Stephen, I completely agree with that. And the only thought I had listening to you was that, we throw these terms around AI, machine learning, neural nets, et cetera, probably more casually than they deserve to be. But now you mentioned Path AI, whose approach to AI has felt to me like what they do is a much better job of identifying the factors that cause people to retest certain ways. And then they integrate that and there's a reduced variance for our test readings. Whereas machine learning or neural nets might be better for some of the things you're talking about, where you actually have to go get different factors and different elements of information and bring them to the party. Now, that could be called AI also. It's just a question of how people use the terms. I agree with you. I think it's going to be pivotally important that we get smarter about what to do in the indeterminate ranges. However we do that, I think it's exciting if we can bring multiple disciplines and determinations. And as I say, people from other diseases other than hepatology to the party, because they've done that work in their spaces and they've learned things. All right, let's go on to Friday.
On Friday, there are more therapeutic trials that are going to be reported on. One of them that I think will be very interesting is abstract AS074. Which is entitled Novel First-in-Class Fatty Acid Synthase Inhibitor TVB 2640 versus placebo demonstrates clinically significant reduction in liver fat by MRI-PDFF in NASH, a phase 2 randomized controlled trial, which is entitled Fascinate 1. The paper is going to be presented by Rohit Lumba from UCSD, and that's on Friday from 11:15 to 11:30. The class of inhibitors of fatty acid synthase is, I think, really important in NASH. We know that fatty acid toxicity in hepatocytes is a key driver of the pathophysiology of NASH, and this is a critical step in the development of fatty acids in hepatocytes. So it's a target that pharma companies and biotech companies have been very interested in for some time. And to my knowledge, this is the first phase 2 trial to really look at this with MRI-PDFF and get a good view of how inhibition of this important target might be involved in NASH therapy. So I'm really looking forward to the results of this clinical trial.
So I selected 2 abstracts for Friday. The first one is abstract 075. Obeticholic acid improves experimental non-invasive markers of NASH and advanced fibrosis. This is a secondary analysis of the phase 3 Regenerate study. This will be presented by Jérôme Boursier from France on behalf of the co-authors. He's been involved in non-invasive testing in NASH for a few years. And this will be presented in the session NAFLD Pharmacological Therapy. So it's Friday, August 28th from 11 to 12:30. And the reason I selected this because we do have several non-invasive tests that can accurately identify patients with F3, F4 fibrosis at baseline. More recently, Stephen and colleagues developed a score called the FAST score, where you can predict patients with NASH and significant fibrosis, which is basically an NAFLD activity score of 4 or higher, and F2, F3 fibrosis. But when you look at a non-invasive test to predict response to treatment and assess the efficacy of drugs, I think we are still lacking good data. So I'm assuming that in this study, they would look at several of the non-invasive tests that were available during the phase 3 Regenerate study, including liver stiffness by FibroScan and some of the serologic markers, and potentially also looking at the FAST score, which is a combination of FibroScan and AST, where you look at three numbers: the CAP score for steatosis, transient elastography for stiffness or fibrosis, and AST for inflammation, and then you get a score. And although this has been validated in several cohorts to predict at baseline the presence of significant fibrosis with NASH, we don't have data to see how it responds to treatment. So I'm hoping to see some of this data at the EASL meeting. I think what we need to get to is, move on from biopsy to non-invasive tests to find out one of three scenarios when you start pharmacologic therapy. You're going to have drugs that will be futile after a period of time. You say, hey, this drug is not working. We need to stop it and maybe look into something else. So we need a futility endpoint. We need to also identify what we call partial response, where you may consider adding another drug to improve efficacy, and then maybe complete response, where you say that my patient is responding adequately to a single agent and there is no need to add anything else. So, again, we need that data on non-invasive tests to see if we can actually get to that point and avoid multiple biopsies in each patient. So that's the first abstract I selected. The second one is abstract 016, combination therapy with dual chemokine receptor 2 and 5 antagonist and the fibroblast growth factor 21 or FGF21 analog synergizes in ameliorating steatohepatitis and fibrosis. This will be presented by Tobias Purngel from Germany, and this will be presented at the session NAFLD Target Identification and Drug Pipeline. It'll be from 3:30 to 5 p.m. on Friday. And the reason I selected this abstract is just to highlight the concept of combination therapy in treating NASH and significant fibrosis. And I think we realized that in most of the clinical trials we have that these drugs are effective, but they're not anywhere close to what we see, for example, with hepatitis C treatment. So we are not seeing response rates in the 95 percentile range. And there's definitely room for improvement by doing combination therapy. And, when I think about the pipeline of NASH drugs, I divide the medications into three big categories. So you have what we call metabolic drugs, and this is where, FGF21, GLP-1 agonists, some of the PPARs fall into. We have drugs that target more liver inflammation, hepatocyte injury, apoptosis, and then the last category is antifibrotics. And what we learned with the medicine called cinacriviroc, which is a CCR2/5 antagonist, that it has mainly antifibrotic effect, although the mechanism of action works mainly on decreasing monocyte recruitment into the liver and the downstream pathway. But cinacriviroc, when they looked at it in a phase 2 trial, showed antifibrotic efficacy at year 1, which was lost at tier 2, and now it's in a phase 3 program, so we should have that data in the future. And then FGF21, we have several companies with pipeline that includes FGF21, including BMS with the most advanced program, and more recently Akero had impressive data that they announced in a press release. So potentially combining a metabolic drug like an FGF21 agonist with an antifibrotic drug could be a good way to tackle the disease. We've seen a few few failures with just targeting fibrosis, and I think it makes sense because you're not really targeting upstream. So all these, free fatty acids leading to hepatocyte injury and recruitment of macrophages, activation of hepatic stellate cells, you're not stopping any of this until you get to fibrosis. So I think probably you need to target upstream, downstream, and utilize combination therapy.
So I chose abstract 77 for Friday. This is Rohit Lumba's discussion on MRI-PDFF to predict response in NASH biopsies. It's a secondary analysis of the resmetirom phase 2b trial. And I picked this because I actually know a little bit about this abstract as I'm on it as well. And there was actually a press release out about this abstract when it became known that EASL was going to be delayed from April until August. So we do have a little more insight into what's going to be presented. And I think it's worthy of a teaser here for the group and the podcast. And so ultimately, it was kind of this study is a relook of the phase 2b trial, and the cohort was assessed for those that had a greater than 30%, greater than 40%, and greater than 50% decline in MRI-PDFF between baseline and week 12. And this analysis was done to look at predictors of NASH resolution. And so ultimately about 107 NASH patients with paired baseline and week 36 liver biopsies were included. So it was the results so far look promising, and I'm anxious to see how this gets teased apart a little bit more in the overall presentation. But the overall mean week 12 fat reduction was 56%. But I think more importantly, when you start getting into these what we call super responders, those patients having a 50% relative drop in liver fat, that's where we begin to see some fascinating data. We already know 30% reduction in MRI-PDFF has been linked to a higher odds of NASH resolution. And in this particular study, that was 40%. The odds ratio was 18. However, the percentages with NASH resolution are actually higher with greater reductions in liver fat content, greater than 40% and greater than 50%. In fact, the odds ratio for NASH resolution when you get to that super responder of greater than 50% liver fat reduction was 25.3. So that translates into, in this particular study, about 64% of patients achieving that 50% relative reduction in liver fat had NASH resolution, which I think is incredibly impactful as far as looking at a single test to predict response to therapy. So there's one more important fact from that, and that is further analysis was done to look at the association with NASH resolution to fibrosis reduction. Turns out in those people achieving NASH resolution, about 60% had fibrosis reduction as well. So there's more to come here. That's just a little teaser, I think, as to what's available in the public as a press release. And more data will be forthcoming.
I'll go quickly because I want to have a little bit of time at least to talk about day 3. I chose AS15, therapeutic effect of a novel long-acting GLP-1 GIP glucagon triple agonist in animal models of NASH and fibrosis. This is a single peptide that does 3 things at once. We know that the value of GLP-1s in a variety of different settings. GLP-1 glucagon is being looked at extensively right now in NASH. In fact, AstraZeneca has an agent, and so does Altimmune. And so in that regard, this is one step forward. The other thing that's interesting is that the company in question, South Korean company called Hanmi, has been presenting papers for years demonstrating a whole range of protective effects of this peptide, ranging from neuroprotection to bone density in obese osteoporotic patients to NASH. And as they've been working down the chain, it'll be interesting to see if any of these things start to come together in a way that suggests that there is a disease they can hang their hats on first to get there. So I'll be fascinated to see what they come up with. Day 3, or third set of papers.
On Saturday, one of the most exciting sessions for the entire meeting are the late breaker abstracts. And I've chosen a late breaker to talk about. It's LB004, and it's the ATLAS trial results. It's entitled Safety and Efficacy of Combination Therapies, including Cilofexor and Furcosistat in patients with bridging fibrosis and cirrhosis due to NASH results of the phase 2b Atlas trial. And as many of you will remember, Gilead did 2 large trials with selonsertib, which was in pre-cirrhotic NASH with bridging fibrosis, and a second study with cirrhosis, and those trials did not show significant results. Well, before they read out those trials, they initiated the Atlas trial, which included selonsertib and multiple other combinations. And one of the combinations was cilofexor, an FXR agonist, and fracosistat, an ACC inhibitor. And while the Atlas trial top-line data did not demonstrate statistical significance, there were some interesting findings that suggested there may be some effect. And in fact, Gilead hinted that secondary endpoints were very interesting. So this is going to be, kind of a full scientific analysis of that presented by Rohit Lumba. I'm very much looking forward to seeing how this combination is analyzed in the Atlas trial. So more to come on that.
Just want to echo Peter's comments. Saturday, Late Breaker Saturday, seems to be really gearing up to be a fantastic day, certainly for the field of NASH, with a couple very provocative abstracts being presented. So in addition to the one that Peter spoke about, which I'm anxious to hear more in reference to the outcomes, I'll be talking about Late Breaker 001, which is one that I'm going to be giving on positive top-line results from a 24-week randomized double-blind placebo-controlled multi-centered phase 2 study of the FGF19 analog aldafermin, previously known as MGM-282, in patients with non-alcoholic steatohepatitis. Anita Coley is my co-author for that, and also a partner with Naim in Phoenix, Arizona. So, as many of you have been following aldafermin's development along the way, this is kind of another iteration in expanding the treatment duration of the 1 milligram cohort. If you remember, historically, we originally studied 6 milligrams, 3 milligrams compared to placebo in a non-invasive endpoint fashion. That data was published in Lancet a couple years back. And off of the significant impact on liver fat content reduction as well as liver chemistry improvement, we subsequently did a 12-week paired liver biopsy study in an uncontrolled manner with a 3 milligram dose and then a 1 milligram dose as well, and saw some pretty interesting results relative to fibrosis improvement. And so the decision was made to then carry that 1 milligram dose forward for 24 weeks, basically doubling the treatment duration to see if giving the liver more time to heal in the setting of the fact that the liver fat has significantly reduced and in a lot of cases completely eliminated, that there might be a better impact on fibrosis. So that's ultimately what we're going to be talking about is what happened histopathologically to these patients in this double-blind placebo-controlled 1 milligram dosing cohort.
Thank you, Stephen. So finally, I started by talking about staging and storytelling, and I want to end by talking a little bit about staging. One of the problems I've always observed in meetings like this is that after late breakers, fundamentally the meeting's over. There are events going on, but nothing that folks are all that interested in. And these are some fantastic late breakers. That said, EASL did something very interesting, which they put a special section on COVID and the liver later in the day after the late breakers, which I'm tremendously excited about. And 2 back-to-back presentations, one from Eleanor Barnes from the UK and one from Tom Hemming-Carlson from Norway, are titled Data from International Registries followed by Risk Factors for COVID-19. And given that this is a liver symposium, I expect that what they're going to be talking about, first is what the data shows, as the first title says, and then the degree to which liver and what about the liver conveys an independent risk factor for risk of COVID-19, and at what level does that risk occur? Is it about morbidity? Is it about mortality? Is it about asymptomatic involvement at all? Since this really is the third avenue for fatty liver to translate into outcomes, I expect this work will provide tremendous amount of guidance in pushing us forward on that. So between the late breakers and the COVID and the liver section, it's a Saturday, but I think I'm going to be glued to my computer from like 4 a.m. East Coast time until whenever the session ends, maybe even longer than that. Those are the last 2 days. Peter, Stephen, Naim, anybody, questions, comments, ways to put things together before we go to close?
I just want to make a comment about the Atlas trial with Gilead that Peter discussed. So it's, in full disclosure, I'm the last author on this abstract. So I'm familiar with the data, but what I'm going to discuss was also in the press release. So if you look at the combination of cilofexor and firsocostat, the primary outcome was fibrosis improvement by one stage without worsening of NASH. And that was achieved in about 21% compared to 10% in placebo. And this was not actually significant. But what's important about this, that there was actually improvement in other biomarkers, including simple ones like AST, ALT, also cytokeratin 18, which is a biomarker of hepatocyte apoptosis. And there was also a signal with liver stiffness. So it's not just histology. It seems like there's more to the story. And the other thing to point out that this was a study in F3, F4, and they had about 55% cirrhotics in the study. So this is a more advanced disease cohort, so it's important to keep that in mind. So different than the intercept cohort in Regenerate, which was mainly F2, F3, what we've seen in primary analysis. So just wanted to point these, 2 points, that this was a sicker patient population, and there was more to the story than just histology. There was improvement in other biomarkers.
Well, thank you for that, Naim. That's exceptionally helpful. That ends today's episode. First discussion we're having on EASL. We will have more over the next few weeks, and then we will have special coverage of EASL we'll be talking about soon. I want to thank Stephen. I want to thank Peter. Particularly, I want to thank Naim, who we called at 12:30 this afternoon East Coast time, and who was on the podcast ready to go and well prepared 3 hours later, which is just spectacular. Much appreciated.
Really appreciate you.
Just happy to have you. In fact, Naim, as Stephen said, you do well, you might get invited back. I think that's a virtual certainty. So thank you for that. Beyond that, as I say, as we put together our EASL coverage, we want to know what you want to know. So send us emails. If you know us personally, call us or text us. Send questions or comments to surfingnash.com, and we will use your feedback as we formulate exactly how we're going to handle this. That wraps up episode 15. We'll be back next week for episode 16, our Sweet 16, if you will. We'll probably be talking more about EASL. We will have Louise back. I'm sure we'll be talking about other interesting topics, and we look forward to getting your feedback on EASL. Special thanks to our new engineer, Mike Wilson, audio engineer excellent, recording buddy of my friend Michissippi Mick Kolassa, who's made us sound so good this week. And an extra special thanks to you folks, our subscribers and listeners, along with your 2,000 plus surf mates who've made us the largest fatty liver podcast in the world. And we keep doubling every month. Tell your friends, get more people to come. The more people come, the greater impact we can have on how medicine looks at liver disease. And I think that will be good for everybody. We will be back on Thursday, July 30th with episode 16. We'll have something juicy. We'll talk more about EASL. Until then, stay safe. Surf on. We'll see you next week.
You've been listening to Surfing the NASH Tsunami. Send in your questions to surfingnash.com, and our panelists will spend the first 5 minutes of next week's episode answering your questions. Visit us online today, surfingnash.com.